Pancreatic cancer prognosis, understanding outcomes and survival. Pancreatic cancer remains one of the most challenging malignancies to treat, with prognosis heavily influenced by stage at diagnosis, tumor characteristics, and patient factors. Understanding prognostic indicators helps guide treatment planning and realistic patient counseling. Overview of pancreatic cancer prognosis. Pancreatic cancer presents one of the most formidable challenges in modern oncology, characterized by aggressive biological behavior and often advanced disease at the time of diagnosis. The prognosis for patients with this malignancy remains guarded compared to many other cancer types, reflecting both the inherent aggressiveness of pancreatic tumors and the frequently late-stage presentation. Understanding the factors that influence prognosis is essential for clinicians to provide accurate prognostic information, guide treatment selection, and help patients make informed decisions about their care pathway. Stage-based prognosis and survival statistics. The stage of pancreatic cancer at diagnosis represents one of the most influential determinants of patient outcomes. Stage designation encompasses the size of the primary tumor, extent of local invasion, involvement of regional lymph nodes, and presence of distant metastases. These elements collectively determine the aggressiveness classification and guide therapeutic recommendations. Stage I pancreatic cancers, which are localized tumors without regional lymph node involvement, historically demonstrate improved survival compared to advanced stage disease, though even these early-stage cases carry significant mortality risk. Patients diagnosed with resectable pancreatic cancer, where surgical removal of the entire tumor is feasible, generally experience better outcomes than those with locally advanced or metastatic disease. 5-year survival rates for resectable disease typically range from approximately 15 to 25%, representing a substantial improvement over unresectable presentations. However, it is important to note that the majority of newly diagnosed patients present with either locally advanced or metastatic disease, limiting surgical intervention possibilities and resulting in considerably poorer overall survival statistics. Median overall survival for all pancreatic cancer patients combined remains approximately 6 to 12 months, though this varies significantly based on treatment receipt and individual patient factors. Histological and molecular prognostic factors. Beyond anatomic staging, the biological characteristics of pancreatic tumors profoundly influence their behavior and clinical trajectory. Adenocarcinoma represents the most common pancreatic cancer histotype, accounting for the vast majority of cases. However, other histological variants exist, including neuroendocrine tumors that arise from the endocrine cells within the pancreatic tissue. These neuroendocrine neoplasms, sometimes referred to as islet cell tumors or pancreatic endocrine tumors, frequently demonstrate markedly different clinical courses compared to conventional adenocarcinomas, often with more indolent behavior and improved prognosis when appropriately managed. The grade of differentiation, ranging from well-differentiated to poorly differentiated tumors, serves as another critical prognostic indicator. Well-differentiated tumors tend to grow more slowly and carry better prognosis, while poorly differentiated, high-grade tumors often behave more aggressively and correlate with shortened survival. Emerging molecular and genetic analyses have identified various mutations and chromosomal alterations that may predict treatment response and survival outcomes, though these remain largely in the research domain and are not yet uniformly incorporated into routine clinical practice for all patients. Resectability status and surgical outcomes. Key points: resectable disease, tumors without vascular involvement allowing complete surgical removal, associated with 5-year survival rates of 15 to 25% when surgery is followed by adjuvant chemotherapy. Borderline resectable disease, tumors with limited vascular involvement requiring careful surgical planning and often neoadjuvant therapy before surgery, intermediate prognostic category. Locally advanced unresectable disease, tumors with extensive vascular involvement precluding surgical resection, managed with chemotherapy and radiation, median survival typically 12 to 18 months. Metastatic disease, presence of distant organ involvement, carrying the poorest prognosis with median survival of 6 to 12 months even with treatment. Role of treatment in prognostic outcomes. The receipt of appropriate multimodal therapy substantially impacts prognosis and survival in pancreatic cancer patients. For resectable disease, surgical resection followed by adjuvant chemotherapy has demonstrated survival benefits compared to surgery alone. Chemotherapy regimens, particularly gemcitabine-based or newer combination approaches like FOLFIRINOX, have shown improved outcomes in various disease settings. The administration of neoadjuvant therapy, chemotherapy delivered before surgery, in borderline resectable cases may improve the likelihood of achieving negative surgical margins and subsequently better survival outcomes. For unresectable locally advanced disease, combined modality treatment with chemotherapy and radiation therapy may provide survival advantages compared to single-agent approaches. Patients with metastatic pancreatic cancer receive palliative chemotherapy aimed at extending survival and controlling symptoms, with modern chemotherapy combinations extending median survival from approximately 6 months to 10 to 12 months in treated populations. The ability to tolerate treatment, maintain performance status, and receive complete planned therapy courses also influences actual achieved outcomes. Patient-related prognostic factors. Individual patient characteristics significantly influence prognosis and treatment tolerance. Performance status, the patient's functional capacity and ability to perform daily activities, serves as a crucial prognostic indicator in pancreatic cancer. Patients with excellent performance status tolerate intensive therapies better and achieve improved outcomes. Age at diagnosis, while important, is less of a limiting factor than it once was, as appropriately selected older patients can tolerate modern chemotherapy regimens effectively. Comorbid medical conditions including diabetes, chronic pancreatitis, obesity, and hepatic or renal dysfunction may negatively impact prognosis by limiting treatment tolerance or indicating underlying compromised physiologic reserve. Weight loss and nutritional decline represent important adverse prognostic indicators, reflecting tumor burden and metabolic stress. Genetic predisposition factors, including hereditary cancer syndromes such as BRCA mutations or Lynch syndrome, may influence treatment options and family screening considerations but do not necessarily worsen individual prognosis when appropriate surveillance and treatment are implemented. Laboratory and imaging prognostic markers. Several laboratory parameters can provide prognostic information in pancreatic cancer patients. Carbohydrate antigen 19-9, CA19-9, a tumor marker produced by pancreatic cancer cells, correlates with disease burden and prognosis. Elevated pre-treatment CA19-9 levels and failure of the marker to decline significantly after therapy initiation both carry adverse prognostic implications. Measurement of baseline CA19-9 and tracking its response to treatment can provide insights into treatment efficacy and disease trajectory, though CA19-9 alone is insufficiently specific for diagnostic purposes. Imaging characteristics visible on computed tomography or magnetic resonance imaging, including the extent of tumor involvement with surrounding blood vessels, presence of distant metastases, and radiographic appearance of lymph nodes, contribute to prognostic assessment. Radiologists increasingly employ detailed measurement and reporting systems to characterize resectability and guide therapeutic planning. Response to therapy on follow-up imaging, indicating tumor shrinkage or disease control, carries positive prognostic implications compared to progression on treatment. Special considerations in neuroendocrine pancreatic tumors. Pancreatic neuroendocrine tumors merit specific prognostic consideration due to their distinct biological behavior compared to adenocarcinomas. These tumors arise from the hormone-producing endocrine cells within the pancreas, and their behavior ranges from indolent to aggressive depending on grade and stage. The traditional classification as islet cell tumors encompassed functional tumors secreting hormones such as insulin or gastrin, as well as non-functional tumors identified incidentally or through mass effects. Prognosis for pancreatic neuroendocrine tumors depends substantially on grade, determined by mitotic rate and Ki67 proliferation index, size, and stage at presentation. Well-differentiated, low-grade tumors, particularly smaller lesions confined to the pancreas, may be observed without immediate intervention if asymptomatic. Conversely, poorly differentiated neuroendocrine carcinomas represent highly aggressive tumors with poor prognosis rivaling conventional adenocarcinomas. Understanding these distinctions is crucial, as the management and expected outcomes differ considerably from typical pancreatic adenocarcinomas and require specialized expertise. Emerging prognostic technologies and personalized medicine. Contemporary advances in genomic sequencing and molecular profiling are beginning to enable more personalized prognostic assessment in pancreatic cancer. Comprehensive tumor genomic analysis can identify specific mutations and molecular subtypes associated with treatment sensitivity or resistance. Circulating tumor DNA analysis, which detects cancer-derived genetic material in blood samples, shows promise for early disease detection and monitoring therapy response with potentially improved prognostic value. Liquid biopsies and other emerging biomarkers may eventually enable more precise prognostication and treatment selection, though these remain largely investigational outside specialized centers. Counseling and managing prognostic uncertainty. Providing patients and families with accurate, compassionate prognostic information remains a cornerstone of ethical cancer care. Oncologists must balance realistic discussion of expected outcomes with hope for individual variation and potential treatment benefits. Population-based survival statistics inform general expectations, but individual patient outcomes frequently diverge from average figures. Discussing prognostic uncertainty, acknowledging the variable course of disease, and exploring patient values and goals of care facilitates better decision-making and alignment of treatment choices with patient priorities. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.